When we talk about patient safety, we often think of hospitals, systems, protocols, and policies. We think about what happens at the bedside when something goes wrong. But patient safety failures rarely begin there. They begin much earlier. They begin in how we teach, what we assess, and what we silently accept. A patient receiving the wrong medication is rarely the result of one careless act. It is often the result of a missed habit, a check not performed, a question not asked, a learner never taught to pause. Patient safety doesn't start in hospitals. It starts in classrooms, simulations, and clinical teaching spaces. Why educators matter? Globally, most patient harm is preventable, and much of it is linked to systems, communication, and decision making, not lack of knowledge. Safety behaviors are formed during training. If education focuses only on getting the correct answer, we may produce graduates who are knowledgeable but not prepared to practice safely in complex environments. Curriculum design is not patient safety design. What we reward becomes behavior, what we ignore becomes risk. What are we really teaching? Let's take prescribing. Students learn drug names, standard doses, and guidelines. They memorize, they practice, they prepare for exams. But prescribing safely is not just about knowing the right drug. It is about knowing when to slow down, when to question, when to say, I need to check. If prescribing is taught as speed and accuracy, students learn that completing the task matters more than completing it safely. And that is not the lesson we intend, but it may be the one they receive. Real-life educational practices that make a difference. Across the world, regardless of resources, small changes transform learning. Prescribing exercises that require learners to identify potential errors before finalizing decisions. Simulation debriefs that analyze near misses, not just successes. Interprofessional discussions where medicine, nursing, pharmacy, and allied health learners solve cases together. Bedside teaching what pauses to ask, what might we overlook? These approaches do not require advanced technology. They require intentional teaching. Role modeling, the most powerful curriculum. A rushed ward round, a prescription written without explanation, a hesitant junior brushed aside. Nothing is said, but everything is learned. Students do not just learn what we teach, they learn what we tolerate. As educators, we are not bystanders to patient safety. We are its first safety barrier. Looking forward, education as the first line of defense. Competency-based education prepares professionals for complexity, teamwork, and uncertainty. Patient safety is where systems thinking becomes real, where communication becomes clinical competence, where reflection becomes prevention. Education is not separate from patient safety. Education is where patient safety begins. To conclude, every lecture sends a message, every assessment sets a standard, every clinical conversation shapes future care. So the question is simple. Are we teaching patient safety? Because every lesson we design is a patient safety intervention.